Neoadjuvant and adjuvant therapy for localized upper tract urothelial carcinoma. So here's some disclosures. So the first thing to know about upper tract urothelial carcinoma is that it's a bad disease. So this is data from Dr. Margulis, who looked at 5-year cancer-specific survivals for patients with upper tract urothelial carcinoma who underwent a radical nephroureterectomy. And what you see here is the cancer-specific survival for patients with PT2 disease at 75%, PT3, 48%, and if you have lymph node positive disease, probably about a 2/3 chance that your cancer is going to come back. And when it comes back, has a high rate of mortality. So given this, there's been a lot of interest in trying to improve outcomes. The most notable of these has been the POUT trial. This was conducted by Dr. Bertel. This was a randomized trial of, it was supposed to have 345 patients who had upper tract urothelial carcinoma who underwent a radical nephro-U and were randomized to either receive placebo, surveillance, or 4 cycles of chemotherapy. In this situation, chemotherapy was either cisplatin or carboplatin-based chemotherapy. The trial was actually stopped early because of significant improvement in disease-free survival. So if you look at these, both disease-free and metastases-free survival were improved in the chemotherapy arm. And at 3 years, disease-free survival was 50% versus 71% with chemotherapy. And this really changed the standard of care after this came out. So we all started thinking we should do some chemotherapy after radical nephro-U. Now, importantly, the subgroup analysis was pretty concerning here. So when you look at this, the patients who received cisplatin clearly benefited from therapy. However, those that received carboplatin, the confidence interval did cross 1. The hazard ratio was in the right direction, but certainly gives us just a little bit pause of whether or not all of those patients clearly benefit from carboplatin. Certainly cisplatin here seems to be a little bit better. When they also looked at T3, T4 versus T2, the T2 seemed to benefit less than the T3, T4. So in this, still, for patients who have undergone radical nephro-U, have PT2, 3 disease, or T4 disease, lymph node positive disease, we consider adjuvant chemotherapy, but there are some subgroups that give us a little bit more pause. And the important thing about this is that when you undergo radical nephro-U, this affects your eligibility for cisplatin. So in one study that looked at over 1,000 patients with upper tract urothelial disease, what this showed was that after radical nephro-U, and this is actually how I think about operation right there, that's surgery for me as a medical oncologist, the cisplatin eligibility goes from around 50% down to about 20%. So you lose 30% of people if you are waiting to give chemotherapy afterwards. And what we know about upper tract urothelial carcinoma is that we don't stage it right before surgery. Upstaging to muscle-invasive disease occurs in around 40% of patients who have clinical T1 disease who are undergoing radical nephro-U. And what this says to us is that we really have to be thinking, when we see clinical T1 disease, do they actually have clinical T1? Do they have clinical T2, T3 disease? And should I be thinking about cisplatin even before? Now, it's important to know that of those diagnosed with muscle-invasive disease on final pathology, 90% of them had T1 disease or less. So we are certainly understaging this disease. This has led the field to think about neoadjuvant chemotherapy for patients with upper tract urothelial disease. And honestly, for a lot of high academic institutions, they are doing this pretty regularly. This is one study that was recently done. 57 patients with upper tract urothelial carcinoma, 4 cycles of split-dose cisgem. The primary endpoint was pathologic response. And what you saw here, pathologic response was defined as less than PT2 disease. And what you found was that pathologic response happened in 63%, and a complete response was in 19%. And 2-year and 5-year progression-free survival, or disease-free survival, I guess, 89% and 72%, and overall survival, 93% and 79%. Certainly a very enticing therapy to consider for patients with upper tract urothelial disease who who are fit for cisplatin. We have also been thinking about adjuvant therapy for upper tract urothelial disease. So one of these trials that we've looked at adjuvant therapy was the INVIGOR-010 study. Now, importantly about this study is that this is a study that took patients who had muscle-invasive and upper tract urothelial carcinoma, randomized them to either 1 year of atezolizumab versus observation. And this study was entirely negative. On the heels of this, a very similar study was done with nivolumab instead of atezolizumab. Importantly, this was a placebo-controlled trial as opposed to randomized to observation. And in this study of 700 patients, nivolumab did improve disease-free survival in both the intention to treat and the PD-L1 high population. Certainly the PD-L1 high population, the hazard ratio goes down to 0.55, whereas the intention to treat population was 0.70, suggesting that those who are PD-L1 positive seem to have more of a benefit. No overall survival data is available yet, but this is now FDA approved. So in the United States, the FDA has granted approval for nivolumab as adjuvant therapy for muscle-invasive bladder cancer at high risk of recurrence, which will include upper tract urothelial disease. Important to know that in Europe, this is not approved. So it's only approved in muscle-invasive bladder cancer with PD-L1 high expression. And that's because in the adjuvant therapy, when we looked at the subgroup analysis for the upper tracts, not only did they look like they didn't benefit as much, the hazard ratios are going in the wrong direction. Here the hazard ratios are 1.23, 1.56. It is poorly understood. It is small subgroup analysis, very difficult to really interpret this. And we should all be ashamed of ourselves for putting so much weight on subgroup analyses. But you can't deny those numbers. So it gives us all just a little bit of pause. So here are the most important things that I would take away from thinking about perioperative systemic therapy for upper tract urothelial disease. So perioperative chemotherapy improves progression-free survival, likely overall survival. Cisplatin is clearly better than carboplatin, but carboplatin's not nothing. Neoadjuvant chemotherapy should be considered in all patients who are cisplatin eligible. But if we are to do this, we are likely overtreating patients with T1 disease. And adjuvant nivolumab can be considered, but its role in upper tract urothelial carcinoma is not clear. Thanks a lot.